All right, welcome everybody. We're going to let Nicholas Parkhill kick everything off. Nick, I think you might be muted.
Nick, you'll need to take yourself off
Nick,
mute.
you're going to have to take yourself off mute. And illustrious start
a great
for us all.
start, an illustrious start for us all.
Let's try that again.
That's the first and only gremlin that we come across this afternoon.
We are live, that's fine.
We are live. Now, just on that, my notes. So good afternoon, everyone, and thank you, Maeve. For everyone that doesn't know me, my name is Nicholas Parkhill, and I'm the CEO at ACON. I'd like to welcome you all to this afternoon's community forum. I'd like to start off this afternoon by acknowledging the traditional owners of the lands that we're meeting on, certainly across all of New South Wales and possibly Australia, and pay all of our respects to their elders, past, present and future. Always was and always will be Aboriginal land. This, as you would know, is a new type of forum for ACON. And while we're hoping that it will go seamlessly, more seamlessly than I've started, please be aware that, like everyone, we're also adapting to new technologies and new ways of working. So in saying that, I'd like to thank you all in advance for your patience and understanding for any gremlins that we may come across over the course of the next 90 minutes. I also do want to highlight at the get-go that it is being recorded. We have formatted the proceedings, so we won't be zooming to the floor, if you like, or onto audience members. But please, if you have concerns regarding this, please be cautious and turn off your video so your face won't be able to be seen. Having said that, it's really only the panelists that you will be able to see. I also do want to apologise. I'm sitting about 3 metres from a construction site, so my speaking will be kept to a minimum. Also, other than the panelists, everyone in the forum will be muted, so that helps us better manage that background noise. In preparing for today and to assist streamline and better manage our time together, we've been asking people to submit questions prior to the forum. The questions that have been received have been grouped into themes, and our panelists are going to try and respond to them in their delivery. Many of the questions that we've received, and certainly others that we're hearing from the community, are also going to be used to inform future content and information that the team at ACON will develop into blogs or other online content, community updates, videos that we will be posting over the coming days and weeks. We'll also be reviewing the chat info that's appearing during the forum. So any questions that come up for you, please feel free to pose them in the chat feed. We won't be able to communicate and respond directly to them as they come up, but they're going to be taken from the chat and compiled into future information for our communities. As I said, this is the first type of this forum for us that we're going to be hosting specifically on our communities and in responding to COVID-19 and the COVID-19 crisis. Today's forum is really to look at broad issues as they're impacting across all of our communities and across the state. And it's a real opportunity to hear from experts, see how they think we're tracking and how things are playing out, what things are looking like now, but also into the future. And of course, what we want to do today is really assure people that we're very cognizant that this is an unprecedented time of crisis, and everyone, as individuals and as communities and more broadly, we're looking at very complex and significant challenges and changes that really everyone is facing. But we are absolutely confident that we can get through this as a community and hopefully, like we have with other health crises in the past, much stronger because of that. As I said, this is the first kind of forum of this type. We want to have other forums like this during the COVID crisis, but they may look at separate issues at a deeper, more granular level, if you like. They may focus on particular population groups, for instance, trans and gender diverse people, our Aboriginal brothers and sisters, people from our communities from Asian backgrounds, or they might focus on specific health issues, for instance, drug and alcohol issues, mental health issues, domestic and family violence issues. Or indeed, we might take a settings-based approach and looking at having future forums, say, that look at the needs of our communities and rural and regional settings. So this is just the first of many. We've taken a broad, more generalist population health approach to this one, but we are very cognizant that these issues are playing out differently for different people in our communities in different areas and with different health issues. And we're very much attuned to that. But in saying that, I'd like to ask that people please be patient with us. As a health organisation, we're too adapting to a new operating environment and balancing, like there are a lot of other health services and NGOs doing. The need for us to be continuing to provide face-to-face services, whether they're food takeaways or home services delivery, transitioning our care support services to online environments, and that takes a bit of time and a bit of adaptation. So your patience for ACON during that process is very much appreciated. Look, we have a terrific lineup of panellists today, and we're so grateful to all of them, certainly for their expertise, their leadership, and the time that they've so generously given to us all today. We're also incredibly privileged to have the amazing Maeve Marsden with us, who will be facilitating today. I'm sure that many of you know Maeve and the extraordinarily fantastic work that she does. She doesn't need much of an introduction, but for those of you who may not know Maeve, she's the producer of LGBTQI+ storytelling project Queer Stories, which has hosted sellout events across the country. And she's also behind an award-winning podcast and a book that was published in 2018. Maeve has moderated events like this for a number of arts and writers festivals, and her writing has been published widely, and she also curates queer thinking for Sydney's Mardi Gras each year. It's a real privilege to have Maeve with us today, and on that note, I'll hand over to Maeve. Thanks, Maeve.
Thanks so much, Nick. Thanks so much. Yes, so my background's in the arts, so I'm having to diversify into health with the absence of that industry for the coming months. I'm really pleased to have been invited to do this forum today. Obviously, you know, coronavirus is all across the news. It's utterly unavoidable. As of this morning, we had, I'm going to check the stats because I'm definitely not a statistician, but 5,750 confirmed cases of COVID-19 in Australia, and 46% of those are in New South Wales. Our communities are in lockdown, and it's often really hard to differentiate, I know for myself, between the useful data that will allow me to protect myself and my loved ones and the misinformation that's spread all over social media. So it's really exciting to have experts who can be able to provide advice. LGBTQ communities have always looked after each other. We've looked after our own. So to have an organisation like ACON mobilise quickly and provide information specific to our community is really wonderful, and they'll help us navigate the coming weeks, days, months. It feels like today has already been a month. At the moment, time is going both slow and fast, isn't it? So anyway, I'm thrilled, as Nick said. Thank you for logging on. You can type questions into the chat, but you can also get in touch with ACON directly with acon@acon.org.au or on Facebook and Twitter as aconhealth. If anything discussed today or broadly in the community at the moment causes you distress, please contact QLife. You can get information on qlife.org.au or call them on 1800 184 527. So our panellists, and I'll ask you to you probably have their names in front of you, but they can give it a little nod as I mention them. Our panellists today are Professor Andrew Grulich from the Kirby Institute in South Wales, Dr. Brad Makai, a general practitioner, Jane Costello, the CEO of Positive Life New South Wales, Dr. Justin Koonin, the President of ACON, Dr. Julie Catt, co-chair of 2010 and the Gay and Lesbian Counselling Service. I'll give more information about each of them as we ask them some specific questions, and then at the end we'll throw to the community questions that were submitted beforehand. So we'll start with you, Andrew. Professor Andrew Grulich is head of the HIV Epidemiology and Prevention Program at the Kirby Institute at UNSW, and has been working in HIV research with gay men for 30 years. Andrew, look, we've heard a lot about COVID-19 being like the flu, but the public health response we've seen would suggest that it's certainly something more than that. Can you please talk us through why the government's response has been so strong?
Well, Maeve, there certainly are a lot of similarities to the flu. I mean, a person who gets this gets a set of symptoms that are not dissimilar. So they feel like they've got fever and chills. They often get a cough, sore throat, muscle ache. So those symptoms are quite like the flu. This is a disease that's caused by an entirely different family of viruses, the coronaviruses, and it comes with a different force, if you like, in that the mortality rate associated with this infection is at least 5 times and possibly 10 times that of the standard flu that comes around each year. And of course, some years we get worse flu than other years, and in which the mortality is greatest. There are certain subgroups in the population who are having very high mortality rates who get this infection. So in people over 80, the mortality rate appears to be over 10%. Over 1 in 10 people who gets the disease passes away. And there's a very high rate of people who get disease that is severe enough that leads to them needing to go to hospital. And in quite a large number of people need to go to an intensive care unit to be ventilated for a period until they get better. And if there's no ventilators available, those people die. So there is a real issue with trying to keep the number of infections below that threshold. And why do so many people get it? The simple answer is that this is an animal virus. It's never before been in humans. It's jumped from an animal host to humans. And that means that none of us have immunity to this virus. With normal flu viruses, some people are vaccinated, some people have natural immunity based on what they've had in the past, but nobody is immune to this virus. And so you put those two things together of large numbers of infections and higher mortality, and we do have an unprecedented situation.
Thanks, Andrew. We've heard some information, more specifically to our communities, I suppose, about PrEP and COVID-19. What's the facts about this relationship?
So, currently we've got a disease in COVID-19 that is untreatable. We don't, while we can ventilate people and some of them get better, we don't have any specific drugs to fight the virus. And in that situation, people are looking at all our known antiviral drugs and what could possibly work. Of course, in HIV, we have a large number of antiviral drugs. So it's natural that people would be excited to think, wow, would any of those antiviral drugs work against coronavirus? The unfortunate fact, though, is that coronavirus and HIV are completely unrelated viruses. They're of different families. They have a whole different mechanism they have different machinery. And so drugs that have been designed to work against HIV are very unlikely to work against coronavirus. There was a bit of a signal with one of the early coronaviruses, the MERS, Middle Eastern Respiratory Syndrome, that one of the drugs called Kaletra, used for HIV, might have activity. The latest trials in the current situation don't look so good, and it's really important to say that if we think of PEP and PrEP, the drugs we use for that target a virus which doesn't even exist in coronavirus. That targets an enzyme which doesn't exist in coronavirus, so it's extremely unlikely that they will work. So we really must assume that they will have no activity against coronavirus.
Thank you. Good to be very clear when misinformation gets around. There's been some discussion online that if everyone during this period of social isolation was to go and get tested and treated for STIs, we could end bacterial infections. What are your thoughts on that?
So, I suppose if there is any silver lining to this terrible situation that the world finds itself in this completely unprecedented situation of physical distancing, is that when people physically distance, they've got to, it makes having sex with other people not possible. So if people follow the guidelines, that means that the ways that HIV and STIs are transmitted are going to be completely interrupted. Now, the person who posted this question makes an interesting point that if when we can move out of physical distancing and move on with our lives again, if everybody got tested before they became sexually active again and having new partners again, well, that would be an amazing way of disrupting diseases like gonorrhea. Having said that, once things are back to normal, and it doesn't take much of the introduction of a new bug to bring things back to normal. But it's genuinely the case that we should see a major decrease in STIs such as syphilis, gonorrhea and chlamydia. I'd also like to make the point that with particular reference to HIV, transmission experts for many years have argued that most HIV transmission occurs from people who have only very recently become HIV infected themselves in the so-called primary infection phase. And that's because at that phase of infection, people often haven't gone on to treatment yet, but also because in the first month or two of infection, viral load is extremely high. We should see if this lasts a few months, we should see that this rate of primary infection goes down to almost zero. So hopefully we will see our already greatly reduced rates of HIV in New South Wales be pressed down even more. It's a little bit of good news in a story which is obviously not good news in general.
There's going to be so many unexpected results of this period of time. And the word unprecedented has been overused, so I won't use it myself. Thank you so much, Andrew. We're going to move on to Brad now, and we'll come back to Andrew with some community questions. Dr. Brad Makai is a general practitioner with a special interest in sexual health and HIV medicine. He's based at East Sydney Doctors, but also works as a radio commentator, TV host, podcaster, columnist, and health and science communicator. He's the host of Embarrassing Bodies Down Under on Foxtel and Channel 9, and will soon be hosting an episode of Catalyst for the ABC. Hi, Brad.
Hello, everybody will be watching because everyone's isolated at home. So that's
Dr. Makai, as a GP, you're usually first line of response for health issues. What should our communities be doing if we're unwell at the moment?
Yeah, at the moment, every general practice clinic is sort of flipping what we've been doing and trying to have a lot more phone consultations. So there are Medicare figures or MBS item numbers that your GP can use to get paid for talking to you over the phone or else doing a video call. And so if you're becoming unwell, if you're wondering what to do, certainly get in contact with your general practice and book an appointment to see them. So some GP clinics have sort of shut down their online services. So if that's not available, please call them. Most of the time we do have receptionists that we've got manning the phones. If you can't get through, then try again because we are quite busy at certain times of the day. But yeah, the first thing is not to panic. A lot of people are getting a sniffle, a bit of a cough, and they're worried that they're starting to get coronavirus. And so there is still plenty of flu, plenty of coughs and colds that are going around. So don't be too concerned, but certainly getting some advice either over the phone with your GP or if you're terribly unwell, go into the emergency department. But for the moment, we're trying to keep people out of the hospitals and out of emergency if we can possibly help it.
Can you tell us about this phrase we're hearing a lot of flattening the curve, what it actually means, why it's important, and how our community can reach that goal?
Yeah, so in very simple terms, I'm a very simple person. If we don't do anything and don't flatten the curve, then it means that we end up having like a big peak of people getting sick all at the same time. They were talking in the UK about having herd immunity. So this was just letting things rip and hoping that enough people sort of survived that they would build up an immunity and then not be able to transmit the infection later on. But the whole problem with doing this herd immunity sort of process is that we get hundreds of thousands of people all sick at the same time. I think some of the estimates in Australia were even like in a single day, 500,000 to 700,000 people being infected at that one time. So you can understand that that if people are all sick all at once and about 1% of those people are likely to die from the infection, and if 20% of those people are likely to need hospital admission and ventilation, then our hospitals would just be overrun, overflowing, and people won't get any care. So if we're able to flatten that curve, so stop everybody from getting sick all at once, then we can delay that process. So people will slowly get the infection over a period of time. And so it brings the top part of the peak down. It means that we have more infections around Australia over a longer period of time, but hopefully our hospitals will be able to cope. And we've seen hospitals not coping over in China and Italy, Spain at the moment, and particularly over the US at present, where we've got sort of like the 65% sort of like beds filled in some of the hospitals around Australia at the moment. The emergency departments are a little bit quiet, but we are expecting more and more people to run in, and we're needing that space that people can go in if they're needing care. So I think that it explains it.
Yeah, it
so
does.
Yeah.
Thank you. We're going to move on to Jane. Jane Costello is committed to effecting change across public health and social policy to better meet the emerging needs of all people living with and affected by HIV across Australia. Her lived experience of HIV and 10 years experience in the NGO HIV community sector in Australia and New South Wales position her as a strong voice representing the interests of all people living with HIV in New South Wales. She's the CEO of Positive Life. Hi, Jane.
Hi, Maeve.
Can you tell us a bit more about what the impact is for HIV positive people in New South Wales or broadly in Australia?
Yes, and thank you for the opportunity to speak today. I think we need to appreciate that coronavirus doesn't discriminate, it affects everybody. And we understand how difficult it is for everyone at this time. And what people are experiencing is very real. Everyone will be experiencing a range of emotions that they may or may not be familiar with. And all of these emotions are valid, and we need to remind ourselves that we're experiencing these feelings as we all do our best to combat the COVID-19 crisis. In regard to people living with HIV, people on antiretrovirals maintaining a viral control above 200 CD4 copies are not immunocompromised unless they have another comorbidities such as diabetes, hypertension, cardiovascular or lung disease. What we're hearing from our community is that people are experiencing a number of impacts though. Some people are anxious about accessing medications from hospital pharmacies or being able to have an appointment with their doctor, and they don't want to go into a medical facility where they may be exposed to COVID-19. With telehealth, people can arrange for their medications to be faxed to a community pharmacy. They can make a teleconsultation with their doctor, and they've still got the option to have that face-to-face appointment where needed. And depending on how long you've been living with HIV for and how long you've been maintaining an undetectable viral load, your doctor might relax the requirements for routine screening as well. We've also heard from people living with HIV who are Medicare ineligible, and they've previously been importing their medication, and they're now not able to get this from their country of origin. So we've been working one-on-one with people living with HIV who are Medicare ineligible to ensure that they can continue that treatment. With regard to housing, there have been issues with temporary accommodation, which is filled up, and those facilities are not taking any more clients. People are finding it increasingly difficult to lodge housing applications, which now have to be done online or by phone. And this is challenging for people who don't have internet access or have to wait on the phone for hours. And when you're homeless or couch surfing, it becomes increasingly difficult to physically distance, obviously. And that's all placing considerable strain on our resources. But likewise, up here, navigators are experiencing increasing demands relating to employment options and access to emotional support and care.
You touched on this, but I'd like you just to expand a little, because there's been a lot of discussion about the virus and immunocompromised people. Do all positive people need to be concerned, and how do treatments affect the risk?
Look, as I noted previously, people on antiretrovirals, if you've maintained a CD4 count above 200, they shouldn't be considered immunocompromised. Those who are undiagnosed may experience and have different outcomes, and they may have a more difficult outcome, but we've got very little data on this, as Andrew has said. To be clear, people should still keep taking their medication as prescribed. They need to ensure they get their flu shot and keep their other vaccinations up to date. And now's the time to take advantage of telemedicine for routine script refills and support counselling if needed. While there's been a suggestion that HIV treatments are being used in clinical trials to prevent or treat COVID-19, and the clinical evidence trial is not there. It's only one HIV antiretroviral, as Andrew said, Kaletra, and it's not in generalised use. So antiretrovirals are not considered protective against COVID-19. In response to the questions we've received from the community, we've created a specific COVID-19 page on our website, and it's got practical tools and strategies for people living with HIV in New South Wales around COVID-19. You can find that on positivelife.org.au.
Awesome, thank you, Jane. Justin, so we've got Justin Koonin. Justin has worked within LGBTQ community organisations for over a decade and is the former convener of the New South Wales Gay and Lesbian Rights Lobby. He trained as a mathematician and currently works as an investment analyst and is the president of ACON. Hi, Justin.
Hi, Maeve.
Justin, ACON works across a range of communities' health needs. Can you talk about some of the populations that may be turning to ACON for support and information at the moment and what ACON can do to help?
Sure, and first can I say how wonderful it is to see so many people joining us. Obviously, it's a really important time for us all. And COVID-19 is affecting every one of us, but as we've heard previously, it's affecting all of us differently and it's affecting some of us more than others. And as we respond as a community, it's critical that we leave no one, and particularly the people who are most vulnerable or marginalized, behind. So I'm going to speak about some of those groups who've been particularly affected. And of course, we know that it's elderly people who are most vulnerable to the actual virus and who've been advised by the government to stay home to the maximum extent possible. And so for the elderly members of our community, we're continuing to provide support and home-based care through our community support network to older members of our community, but also to those living with HIV. And we're also preparing food takeaway packs and delivering meals to their homes. And I'm conscious in saying this, that it's important to remember that all of us, old people and younger people, are vulnerable. And so even though older people are most vulnerable, we all need to take COVID-19 very seriously. It's also true that people in rural and regional areas are particularly affected. A shout out, I know there are people from the regions on the call, so a shout out to all of you, thank you, because there's not always the same access to medical equipment and medical care that we find in major metropolitan areas. And the same is true for Aboriginal communities. Aboriginal people are also more vulnerable to COVID-19 than the general community because of comorbidities, because of the very high proportion of people in these communities who live with chronic diseases like heart disease, kidney disease, cancer. And so our regional offices in the Hunter and Northern Rivers, our outreach programs which run across the state, and also our Aboriginal project are all open and are all working very hard to support those communities. Another group with a unique set of issues that they're dealing with are trans and gender diverse people, because for one, all gender affirmation surgeries have been cancelled at the moment. Also, trans and non-binary people who bind their chests are at a much higher risk of complications from COVID-19 than the general population. And all the issues which we know trans and gender diverse people experience ordinarily in accessing appropriate healthcare, discrimination and violence in healthcare settings, Medicare issues if a person's name and gender are not accurately reflected, they're all magnified at the moment. But I'm happy to report that there's a great new resource which the ACON team have developed. Shout out to Teddy and the team, and which we launched last week actually, called Trans Hub. If you Google Trans Hub, you'll find it. And it's a sort of online one-stop shop for all the issues faced by trans and gender diverse people, including now the impact of COVID-19. And I'd really encourage people to go there. There's also issues for people who use drugs around the supply of safe injecting equipment and other issues. And so we're keeping our physical needle and syringe program open as a critical and essential service. And also our drug and alcohol counsellors are available online or over the phone to provide support. And in the week ahead, we'll also be releasing specific information relating to drug and alcohol use through our website dedicated to those issues. It's called Pivot Point. All of this will be recorded so you can access the information later. I also want to note that there's significant issues for people living with disabilities, even in accessing information about what's going on, never mind trying to physically distance and everything else that we're having to do at the moment. And so we need to be very deliberate about how we address this. It's true too that the virus is also impacting partners and people who've stood alongside LGBTQ communities in our battles for literally decades. And I'm thinking particularly at the moment about sex workers who've seen their incomes disappear overnight. Not all sex workers will be eligible for the government's JobKeeper allowance. Some will, but some will not. And I know that Scarlet Alliance and its member organizations have been doing a fantastic job under really difficult conditions to support those who are most vulnerable. And they've also launched an emergency support fund, which you can find on their website, if that's something you're able to do. And then all of our communities, whether they're women, gay men and men who have sex with men, bi, trans and gender diverse people, all of us have been asking what COVID-19 means for the ways in which we meet, the ways we interact, have sex. And I'm going to say more about that in a minute. So those are some specific examples, but coronavirus is affecting all of us. And so I just want to assure everyone that ACON is open for business to support this community. And I also want to emphasize in closing that this is a whole of community response, of which ACON is one part, but that there are literally dozens of community organizations and hundreds of individuals who've stepped up to support each other. And it's great to see so many of you on this call. And we at ACON are incredibly grateful to you for all of what you're doing. Thanks.
Thank you so much, Justin. Our final sort of formal set of questions is for Julie. Dr. Julie Catt is a psychologist, an author, and has worked alongside and within the LGBTIQA+ communities since she started her career in the US in education and health in 1988. She's been a practicing psychologist since 2000 and in private practice since 2003, with specialist fields including work with young people emerging from home into the wider community, diverse genders and sexualities, and sexual health. As well as being co-chair of 2010, Julie is CEO of a dynamic household, which includes teenagers, young adults, cats, and dogs. Julie, you have a family of your own. How can our families, whether biological or chosen, support each other through what is incredibly unique and potentially traumatic situation?
Thanks, Maeve. First of all, I appreciate the honorary doctorate, but I'm not a doctor.
Oh, really? Did I accidentally copy a doctor from somebody else's name? Look, take it. Everything's upside down at the moment. We're all doctors.
Yeah, but look, thank you for that question. I've been thinking about it a lot over the weekend because personally, it's quite impactful. And I've been thinking about ways to support my own family and my clients and how they can, interact with their families in a way that's safe and also in a way that people feel supported. And, so I've got some of my kids I'm seeing because they live with me. Others, I don't know when I'll see my adult children again, which is, hard to even say out loud. But what we can do is talk a lot. And what I can do with them is talk to them about how this process had a beginning, a middle, and an end. This isn't going to go forever. The impacts we'll be feeling for a very long time, for the rest of our lifetimes, obviously, but this isn't going to be how it is. And so I talk with them a lot about that. I spend a lot of time listening to their anxieties, both my children and my clients, obviously. And what comes up is, how will I manage if this is, as this goes on for months? Can I cope? Will my friends cope? What will it mean for my lover who I can't see? And those kinds of questions. And I keep coming back to the thing of humans are adaptable creatures. We've adapted thus far. If you had told me 6 weeks ago that this would be how my life looked, I would have said, oh, it's unbearable. I can't imagine how I'd cope. But of course, here we are, we're coping, right, in some fashion. So we are adaptable, we have adapted, we will continue to adapt. And I think that bringing that reminder back to people again and again can seem to be quite useful. On a practical level, I take, make food and leave food on my kids' doorsteps. We can, right now, drive places and do things like that with no contact. But mostly what I'm finding is just being an ear, being a place that people can come to and and I can listen to those anxieties and those fears with an open heart. That's key. I was listening to Dr. McKay before talking about, you get a sniffle or you get a scratchy throat and think, oh, that's it. I'm hearing a lot of that, those real health anxieties come up, and kind of talking people down from that has been an important part of my job lately as well. But, I think just accessibility, using the internet as much as we can, obviously, has been imperative. So I think that about covers it in that realm.
Yeah, it does. Thank you. One of I'm going slightly rogue because I saw one of the community questions that relates to this, and I might just add it in as a sort of adjunct, was how can we fit in our ideas about queer family into the advice to isolate, because it seems to privilege cohabiting biofamilies. Do you think you could sort of speak to that idea as well, to this community question from Christian?
Well, yeah, sure. Look, I think this, one of the things that I've heard again and again, and I certainly feel, is the lack of clarity around some of these directives. So what is, how are we defining family? And I think that what's interesting about that to me is that queer folks have been asking that question for a really, really long time. And now it's kind of really on the table. So, I think that this is kind of in a weird way inviting those conversations to happen on a broader scale, which I think is fantastic. I've talked to people who are in poly relationships, for example, and hearing those particular challenges. Who do we get to see and who don't we? And I think that what I'm finding is that people are kind of defining who their family is on the fly through this, for better or for worse. What else are we going to do? And I just think we have to support that and do the best we can through this. We're all muddling through.
Thanks, Julie. In your role at 2010, obviously 2010 works with people in our communities who are marginalised. What can we be doing? How can we contribute to look after young people and people experiencing homelessness at this time?
Well, look, I think that, on a big picture, we need to keep the pressure up on the government to provide support, particularly for people who don't have Medicare benefits. Someone else was saying that as well, that we need to keep the pressure on to support all of our young people who are vulnerable, who may not have access to the same privilege that Australian permanent residents do, but also young people who are homeless, who are in a position where they need to be able to access counseling or case management. At 2010, I woke up a few weeks ago in the middle of the night going, oh my gosh, this is dreadful financially for 2010. How will we keep afloat? And there is some funding that's coming through, and the staff has been fantastic and so agile around being willing and able to work digitally. So we're making sure that our young people know how to access 2010 case management and things like that. We are able now psychologists are able to bulk bill for remote sessions, which wasn't possible not that long ago. So that's another huge win that we've had to push for. Making sure that people know about Q Life, which is running now from 3 to midnight, and there will be someone on the phones, Kids Helpline and things like that as well. And, if you're one of those lucky people and, who's not financially impacted, keep donating to your charities of choice. Keep donating to 2010 or to ACON or whomever, because right now it matters more than ever. Our young people are really struggling with that, with issues like isolation, or if they're at home with their families, that might not be such a safe or comfortable place as well. So it's really, really important right now that they're able to access those services.
Thank you, Julie. We're going to move now to some of the questions from the community that were submitted prior to the session. And these are for individual panelists to answer, but obviously jump in if you've got something to add. We got dozens of questions, so we weren't able to include all of them, but we've tried to condense them based on repeat themes that came up so that we could address as much as possible. So you may not hear your exact phrasing, but hopefully the topic you were interested in is covered. As I said at the start of the session, or if you've just joined us, if the information you needed hasn't been addressed today or hasn't been by the end of the session, you can get directly in touch with ACON. So first up, a question for you, Brad. So if you want to preemptively unmute. There's a lot of misinformation being shared at the moment. Can you give us an update on COVID-19 transmission routes, symptoms, and the treatment or vaccine progress, and maybe address some of that misinformation that we get to hear?
Yeah, sure. Yeah, I got a weird email from my dad this morning saying, "Is it true that that hydroxychloroquine is the miracle cure for coronavirus?" And I looked at the article that he sent through, and it's from like Israel News, so like a weird website that my parents get their Christian news from. So very, very odd. Yeah, so I suppose if we go back to basics like transmission, it's mainly to think of it being droplet spread. So if somebody's got the virus that's replicating in their lungs and they're coughing it out, then that can go into the environment around them. But it tends to drop down with gravity. So so the droplets will sort of, yeah, like fall to the ground within about 1.5 meters or maybe 2 meters from people, which is why we're talking about physical distancing from each other. So of course, if somebody's like sneezing and coughing, yeah, it can go across the room, but for the vast majority of people who aren't coughing in your face, it's probably not going to like waft its way into your mouth. So you can also get it from even people breathing as well. So there are, we do talk about asymptomatic spread, where people can be sick with the virus, but not actually feel sick, but they can still be breathing out the viral particles into the air around them. So this is one of the big problems that we're seeing around the world, that you may not know that you're unwell. And yeah, like the other way, rather than just in the air, is contacts as well. So if you're touching door handles, bench tops, every surface, some people online are saying everything is lava. Don't touch anything when you go out, and make sure that if you do touch something when you're outside your house, then when you come in, you're washing your hands straight away, so you're not going to be touching other surfaces around your property.
I've also heard a glitter reference, that it's like glitter and you're touching things, which I thought was appropriately queer. Sorry, go on.
Yeah, totally. Yeah, just spread around everywhere outside. Yeah. So yeah, there are other memes going around saying, if you could see the virus, would you go outside? So that's an interesting question. I was talking on the hookup a few weeks ago on Triple J, and people were saying, oh, if I'm invited to somebody else's house, then I might feel pressured to have sex with them because we're in an apocalypse. How do I negotiate that sexual behavior? And I was like, why the hell are you going to their house? Like if you walk in there, every surface will be surrounded, like if they do have coronavirus, yeah, and they may not know it, but every bench top, every surface, you could potentially infect yourself and then take that back to your household as well. So I think for a casual sex point of view, this is a real big issue. And I think a lot of people don't quite understand that method of transmission at present. So it's certainly, you're more likely to get if somebody's coughing and spluttering around you. This is why we're worried about health professionals trying to intubate somebody, putting a tube down their throat. And if somebody has a high viral load and they're just spewing it out into their environment as they're very unwell, going into intensive care, then that's when doctors and nurses are getting a big viral load that they're breathing in, and then they're starting off at a really high point of virus, and they can get particularly unwell, and we're seeing a number of health professionals around the world dying from coronavirus. So it's all about a bit of a dose relationship too. So if you're touching a surface, you're unlikely to get all that much virus compared to if you're in hospital. So as far as symptoms are concerned, that was one of the other parts of the question. So yeah, so most people are sort of finding that the main 4 symptoms are having fever, cough, sore throat, and shortness of breath. Some people are finding that they're fatigued, but everyone's fatigued. That's what I find with my patients anyway. Muscle aches are a little bit of a sometimes food when it comes to coronavirus. Headaches, diarrhea with some people as well. And we're just seeing a few sort of stories coming through and a bit of evidence talking about losing a sense of smell associated with coronavirus too. But there are a number of different things that can stop you from smelling properly. So one of them could be coronavirus. So it's not a telltale sign by any means. I think the other part was treatments.
Yeah.
Many
treatment
facets
/ vaccine progress.
Yeah. So with the treatments, I think it's just important for everyone to be really wary of what we're hearing. So yeah, like the US, particularly Trump, is talking about hydroxychloroquine, so an old medication that's used for malaria, in combination with azithromycin. But yeah, the studies so far haven't been very rigorous. Often they haven't had any control groups as well. And people say, yes, I took it and I got better, but then would they have just got better anyway? So we really need to look at that a little bit further. My feeling is that it's probably not going to be a miracle cure for it. I don't think it's going to be, very successful. I've nothing to base on that other than knowing a little bit about the drug and seeing the preliminary trials. So I wouldn't hang my hat on it. And Andrew was talking earlier on about lopinavir and ritonavir and looking at HIV medications. Really important that people know that if they are on HIV treatment or if they're on PrEP, it's not going to be protecting you from coronavirus. So don't be falsely reassured by that. That's really, really important. And I've had lots of patients coming in saying, I'm going to be fine, so I don't need to adjust my behavior at all because I'm on PrEP. And like, this is not the situation at all. So again, I'm not hoping that that's going to be a miracle cure. There's been some discussion recently about ivermectin. So it's a treatment that we use for scabies, treatment-resistant scabies. That again, it's showing in a test tube situation, so in a lab, that it can decrease the amount of coronavirus that's there. But whether that actually comes into being when we're using it in human trials, we have no idea. And if we're using it in high doses, it can be pretty toxic to the human body too. So again, I'm not holding my breath for that. And the other one is, was it remdesivir? So an experimental drug so far. Yeah, it's still a while away until we get some understanding with that. And just to quickly on vaccines as the final part of that, is that, yeah, there's about 35 or more different companies and organizations around the world that are trying to get a vaccine. They were trying with SARS back in 2002 and with MERS in 2012, I think it was. And so they've already started to do a bit of research in coronavirus vaccines. So we're already a little bit ahead of the game. But yeah, we're still needing to take it through all of the trials. Some organizations are doing human trials at the moment, so we don't have to go through animal trials before we go to humans. But again, it's going to be at least until like early next year, if not the middle of next year, until we find something that actually works. And if we're using a shotgun approach and having all these 35 companies or more trying to make it, then hopefully at least one will come up with the goods in the end.
I've just seen a message. No, well done. That was a dense question. I've just seen a message on the Zoom chat, which for everyone tuning in, I am having a look at now because we've been very efficient and we may have time to address some of the live questions. And so, Brad, just while we're here talking about some of this detail, someone's asked how common it is to be asymptomatic. I don't know if those are stats you have to hand or if you can speak broadly to that.
Yeah, I think every study shows something slightly different. The latest information that's come out of China was saying that even the estimate would be even 4 out of 5 people could be asymptomatic and not show anything at all, not know that they're infected. Particularly, kids can be infected with coronavirus and not exhibit any symptoms whatsoever. But also being aware that some kids get extremely sick from this too. I don't know if Andrew has something to add with those figures as well.
Yeah, I'd love to actually, because it really is an important and confusing area at the moment. I think the key thing to remember is that each of these studies has been designed differently. And if you imagine 1,000 people who are all exposed to coronavirus yesterday, and you did that study in them today, you know, many of them would test positive for coronavirus, but nobody would be symptomatic because they're all in the incubation period. And so really what you need to do is a study that follows people over time and then follows them for a week or more after their test to see if they develop symptoms. Now, and when they develop symptoms. The best studies have been those based on from the Diamond Princess boat in Japan, where people were tested regularly. Their estimate is about 15% of people will develop completely asymptomatic disease. So they'll get infection and it run away without symptoms. I think it's really important, though, that people who are asymptomatic are going to be much less infectious for two reasons. One, their viral load is lower, but two, by definition, they're not coughing and sneezing. So yes, some disease is transmitted from these people, that's definite, but it's a minority of the disease. Another optimistic piece of information here is that you've seen the effect in Australia, in South Korea, elsewhere, the effect of isolating people with disease and quarantining their contacts. If you do that without any testing for asymptomatic disease, you get huge decreases in infection. Without, and like in Australia, we're still not testing asymptomatic people for this reason. So my epidemiological assessment of the evidence is, yes, some transmission from asymptomatic people happens, but it's not a lot.
Just forgot to unmute myself, so I'm part of the problem. Thank you so much for those answers. There's a bit of chat happening about casual sex, and so I'm going to move to one of the community questions that was submitted beforehand. Justin, when will it become safe to start having casual sex with multiple casual partners? Can you talk us through ACON's messaging around casual sex that has been released? You still...
Thanks.
There we are.
So I'm hearing lots of loud noises, but I don't know if it's on my side or not. Can you hear me?
It sounds like someone contacting you on Skype.
Yeah, okay. No, that's fine. All done.
We're good now.
Yeah. All right. So this is a really topical question. And the honest answer is that we don't know when it's going to become safe again to start having casual sex with multiple casual partners. And our message at the moment, which hopefully you've seen through social media or via email or on our website, is that we really encourage people to take a break from having casual sex at the moment. And that's not an easy message given how hard we've had to fight for our sexual liberation. And it's a highly unusual one for an organization as sex positive as ACON, but it's a necessary one right now. We're doing this literally to save lives. And in fact, many of the most vocal voices in our community for this position have come from our elders, the people who lived through HIV in the early 1980s and 1990s. And so I want to thank them for what they're doing. I saw a comment in the chat box from Phil Carswell, but I know that there are many others who've also been vocal. So that is our position. And the reason is as described by Brad and others. Coronavirus is transmitted through contaminated droplets spread by coughing or sneezing, or by contact with contaminated hands or surfaces or objects. And so that's why we're all being encouraged to practice physical distancing with people outside of our household. And clearly you can't be physically distancing with someone while you're also having physical sex with them. All of us need to play our part in the flattening of the curve that we describe. And so if you're young and healthy and think that if you contract COVID-19, it's not likely to be a big deal, our message is that, first of all, that's not always true. There are people under 40 in intensive care in New South Wales at the moment. And secondly, it's about all of us playing our part to protect the people who are most vulnerable in our communities and the broader community. So you might be okay if you get it, I might be okay if I get it, but the people whom we could infect might not be okay. But still our message is to remain sex positive. And there are lots of ways of enjoying sex and intimacy with yourself or with others which don't involve physical contact. I'm sure you can think of some of those yourselves, but we've also published some of those on our website and through social media. And perhaps our policy team could put some of those links up in the chat box. But as to how long we'll be like this, it won't be forever, but it's going to take as long as it takes because our health is the first priority.
Thanks, Justin. You mentioned how some of the older members of our community, especially who had experience campaigning around HIV/AIDS, have been really firm in putting this message across. Jane, how can we look after older members of the community who may be having flashbacks or remembering that trauma of the worst days of the HIV epidemic?
People living longer term with HIV will no doubt be thinking about the similarities and the differences during the early days and what's happening now. But the community of people living with HIV, we're pretty resilient, and many of us have also developed our own coping mechanisms. I think given the unusual circumstances we're faced with, if these fall apart, the coping mechanisms, it's really important that we reach out to friends and family or professional counsellors if we're experiencing anxiety and fear, and take advantage of those support networks that have been made available by counselling services, by helplines and other resources. And we've got a history of that. We've had that support right through and from within community as well. And we need to draw on those previous strategies and reinforce our current networks and the way of working. It's about utilising telehealth and speaking to the people who know you and know about your health. But we keep an updated list of services on our website, on Positive Life's website, and we're obviously happy to talk to people who are both living with or caring for someone living with HIV. But it's also important to reach out to those you know who are living alone or have become more socially isolated due to the current physical distancing and voluntary isolation choices people are making. One thing to remember, there's a reason why we call it physical distancing rather than social distancing. But socially, we're all linking up with each other more than ever, even through phone calls, emails, clocking in on social media to reach friends and family, video conferencing like this forum we're engaged in now. I mean, it's all new for us, but we're all engaging with Zoom much more in work, but also socially. People are having virtual meetups and just checking in with people. So I think it's really important we don't distance from each other socially and while we're maintaining the physical distancing. And practically it's about reaching out to the elders in your community. That might be an option for you. Just a quick call to find out how they're travelling, or a 10-minute friendly chat just can make such a difference to anyone. And as I said, Positive Life's always happy to talk to people who are unsure of what to do or where to seek further support.
Thanks, Jane. Julie, there's a lot of people who live alone, and obviously Jane was speaking about some strategies for supporting the more vulnerable in our community, but a lot aren't tech savvy, so connecting with others at this time can be a real issue. What are different organisations doing to support this group of people, and what can we do as individuals both to support them and to maintain our own mental health during this time?
You mean the folks who aren't tech savvy?
Who aren't hopping on a Zoom to play, Scrabble with friends?
Yeah. Well, look, I think that even though I know that, my experience is largely with young people and they're sometimes allergic to taking telephone calls, I think that, that what I'm hearing about and what I'm seeing is that people are sort of starting to do that more, picking up the phone and using it as an instrument that transmits voice, which is, kind of funny to say, but really, there have been people who've been really pushing against that phobia of picking up the phone. And I think encouraging that, and things like QLife, for example, we've had to, at 2010, we've had to do this whole thing where the counselor's in a room alone and it's all sanitized. And because we wanted to prioritize making sure that there is someone to pick up the phone, that there is someone there to have a voice, and to, if you don't feel like doing Zoom and Skype and all of that, you can still do it the old-fashioned way. So in my experience, it's largely with 2010, and that's what we're doing, and I would encourage other organizations to do the same, and push each other around that. I think we can push each other within our communities to find other ways to communicate with one another as well.
Thanks, Julie. Andrew, what are the best expert estimates of how long the restrictions will be necessary or will continue? How long are we going to be like this?
So there is no short and easy answer to this, but I'll give you examples from two fields, and one is based on real data and the other is based on modelling. Based on the real data from places like China and South Korea, you can get the infection rate down towards zero with physical distancing, isolation and quarantine. However, in the period after that, you do get a dribble of new cases at a very low rate. It's unlikely to be the case that this condition can be eliminated, although a place like New Zealand, which is completely isolated and small, potentially possible. The evidence for mathematical modelling suggests that the flattening of the curve that we're talking about, if we did nothing, it would all be over in 3 months, and we would have unspeakable mortality. It would be truly horrendous and beyond comprehension. But by squashing the curve. We're flattening and lengthening it as well as bringing it down. So it will take some months. The question will be, if the numbers keep going down, as they're going down very nicely at the moment in Australia, if they are to keep down, including the local transmission ones going down, then at some stage we might consider taking our foot slightly off the brake and releasing some of the restrictions that we have until we see a rise again, and then really putting our foot on the brake and taking it off over a period of many months until we have a vaccine. Because at the end of the day, until we have either an effective vaccine or a very highly effective treatment, the problem isn't over.
And there's a few sort of quite practical questions from the community list, so I'm going to throw them and see who is up for answering them. One is, are there enough COVID-19 test kits for the Australian population? And I think that there's a lot of fear growing around these kind of things that we hear from what's happening in other countries. So these are kind of blunt questions, but can one of you speak to where we're at with the test kits here in Australia? Anyone?
I'm happy to start it. So Australia has one of the highest per capita rates of testing in the world. So we have better availability than almost anywhere. There have been a few places that have done better than us. Currently targeted testing is still targeted people with symptoms, and until recently it's been people with contacts. But if you also live in a part of Australia where the incidence is high, such as Eastern Sydney or the Northern Beaches, if you have symptoms, you can get tested even without contact. And those regions are likely to expand.
Thank you. We've had a couple of questions here about people in regional areas, and if you'll just bear with me while I find the one that I wanted to refer to. I've got about 1 million windows open here. Someone in the group chat here has said, I'm in an area where currently there is very, very limited healthcare support. And I also know somebody else in the comments said that a lot of people in regional areas are feeling like they're okay because the rates of infection aren't as high. So we've got these mismatched messages of people in more isolated areas being told both to isolate, but also that they might not be at such high risk. This person in the chat has said, my GP is 40 kilometres away and has advised me to remain in isolation for as long as it takes to find a vaccine. Do you think that when the vaccine comes, it'll be triaged with certain people getting priority, or do you think that people in regional areas are going to have this drawn out perhaps even further? Can anyone speak to that, or more broadly to the situation in regional communities? A lengthy pause. Brad, in your role as a GP, are you in contact with rural GPs and what sort of challenges they're facing supporting their communities?
Yeah, so I just feel like Andrew's much more qualified than me at answering it, but I'll answer in my way. So yeah, so certainly there are many GPs who are around in regional areas, and they're sort of struggling at the moment. They're worried, they're anxious about their own communities, and this is understandable. So if you are contacting your GP or your doctor, then know that they may be pretty stressed and worried about what's going on too. A lot of people are wanting more protective gear as well. That's one of the big issues around Australia for health professionals. So we don't get sick, and we're wanting to stay well so we can service you. But yeah, like the other issue like regarding testing is just to sort of be clear about what the testing is. So so certainly at the moment, so far in Australia, we've been doing like nasal swabs and throat swabs. So this is looking for the actual virus that's hanging around in the body. Down the track, we are expecting a number of or hundreds of thousands of kits to arrive any minute now. We're being told by the government. And this is doing a test very similar to doing a point of care HIV test. So it's just a drop of blood on from your finger, and then it gets run through filter paper essentially, and then it tells you if you've got an acute infection now or if you've got antibodies because you've seen the infection already in the past. And so this is going to be a really significant change with how we do the testing, because it's going to be much more accurate than sticking a swab up your nose, and it can also show if if you've potentially got immunity to getting it in the future. And as we were saying before, a number of people will have asymptomatic spread or asymptomatic infection, where they could have it and be immune to it and not know about it. So once that is done, we're sort of like, no, okay, things we would expect you not to get the infection again. Again, that's a bit of a contentious issue. We can talk about that if you want to. But yeah, our understanding is that if you've got antibodies that are showing up on that blood test, that you should be immune to it. So this will enable a few more people to be wandering around the neighborhood, as long as they're not touching crosswalk signals and then taking it back home and then touching their partner's face.
Bluntly put. Another question from the chat. Can Dr. Grulich comment on the Swedish approach? They have medium restriction of movement, so not no restriction like the media has been making out. Is their goal a herd immunity? Have you looked into this specific approach?
Look, I can comment a bit on it. And I should say it's very, very early days to know how Sweden is going to do in the long run. But basically, with the possible exception of New Zealand, nobody is trying to eliminate this virus because we don't think it's possible. And so in that environment, the only thing that gets us out of this pickle is the vaccine. And so you just want to ensure that you don't get to the point where your intensive care beds are full and people die because you don't have intensive care beds. That's where Italy and the US is at now, and it's absolutely horrible. So Sweden is gone to a middle road, if you like, of not aiming to keep it too low. They can keep their shops and a few other places open. That's the benefit. But many, many more people will become infected. Trying to find, that middle point, we really don't know how to do that. I would say Sweden is erring on the side of not restricting enough, and that will show up in the next few weeks. If they're not doing it enough, they will their intensive care beds will overflow and they will have a lot of death. I think we are erring on the safe side. I would say Sweden is erring on the not safe enough side, and my current feeling is that Sweden will not have a good outcome of what they're doing.
Thanks, Andrew. I've got a couple of questions that have come through in the chat, and to be honest, that I had thought of myself as well, and they're not strictly health questions, but they're in areas that really affect our communities. So I thought I'd throw them to you, and if it's more about referencing a different organisation that people can get in touch with, that would still, I think, be really helpful. One of them's around, there's been a couple of questions around our community's history with the police. Obviously, we've had a really increased legal restrictions on our movement. One of the questions here says, I'd be very interested to know ACON's stance on some of the quite draconian measures implemented in New South Wales to ensure physical distancing, and how it, or perhaps another organisation, can provide advice and resources to navigate an evolving and often contradictory legal landscape. So yeah, speaking both to the LGBTQ community's history of difficult relationships with the police and the situation we find ourselves in now, where can people go for advice?
Maeve, maybe I can take that one.
Yeah, that would be great. Thanks, Nick.
It's certainly something that we're monitoring closely. The history of the HIV response and the early fights that the community had to have in response to the emergence of HIV, so rights weren't taken away and community was protected, is something that's still pretty fresh, I think, in terms of the kind of a kind of human rights perspective weighed up in relation to epidemic management or responses, if you like. But then, as you referenced, there's certainly a longer history, I think, that our communities have with law enforcement agencies that's not in the context of public health. It's more in the human rights-based area. So we're certainly monitoring it. And indeed, you will probably see come from us over the coming weeks more information around this. There was a great article, which I know we've shared on ACON social media, that came out of the ABC that referenced some of the work that's being done by the Australian Human Rights Commission, who have seen an increase in complaints that they're dealing with and managing, not just in relation to law enforcement, but I think people's human rights, discrimination, particularly, unfortunately, for Asian people. So it's something that we need to be very, very mindful of. We're we're being told, and I think we can be somewhat assured that the measures are just being put in place at this point in time to make sure that, you know, people are doing the right thing. And I think by and large, people have understood that they need to be in place. But as a community, and I think as a society, this is something that we need to monitor really, really carefully, because often, unfortunately, there can be a fine line. And I think by and large, you know, law enforcement is trying to do the right thing, but you know, human rights, particularly for our communities, have been hard fought for. I don't think that we're there yet. There's a long historical kind of legacy of where we haven't had them. And so it's a great question. And it's something that I think organisation like ACON and so many other LGBTQ organisations are monitoring.
I've just seen here in the chat that Anna Brown from Equality Australia has said that they are working on fact sheets and resources about legal issues and policing response. So that's great to know. Was someone else just piping up? Did I hear somebody else say, Maeve? Justin. Did you want to say something, Justin?
Yeah, it was me, and about to say exactly the same thing you said.
Oh.
Australia is a great resource around human rights and legal issues. Anna, maybe you can put the Equality Australia website in the chat box so people have it. Thanks.
That would be great. And this is another kind of adjacent question, which is someone's put into the chat, which is how can we advocate and support our community members who have lost jobs? Welcome, I'm with you, and are being evicted in the middle of this nightmare. Does anyone, either general advice, Julie, is this something you could speak to?
Yeah. Look, I think, again, going back to youth focus from myself, you know, that's one thing that 2010 does very, very well, is helps young people navigate those processes. I can't imagine what it would be like to have to apply, do all that applying, and I think and particularly for young people, you know, doing that level of administration can be really challenging. So I think it's very, very important to make sure that there's access to someone who's knowledgeable and can help navigate through. And I know that we do a lot of that anyway. And I'm imagining that right now we're doing a whole lot more. So, yeah.
Nick?
I think too, certainly for people in Sydney, they can also tap into the Inner City Legal Centre, and also for HIV Positive Centre, the HIV AIDS Legal Centre, which is co-located in the ACON building, and then transitioning to digital workspaces. So fortunately in the inner city of Sydney, I think there are those organisations that are very community connected and attached, but similarly, people can also be looking towards their community legal centres, which are established across the state as a resource as well.
Maeve, I just wanted to say also, Positive Life, we have peer navigators who provide both housing support, as I mentioned before, but also return to work options. So we do support our community in those ways, and that can be done remotely. So it can be done over the phone for people in rural and regional areas.
Julie, you wanted to also add something? Yeah,
I just noticed in the chat that's coming up that the Tenants Union is a great resource as well around what your rights are as a tenant in terms of rent relief. So, yeah.
That's great, thank you. I think we're sort of coming to the end of time for questions, but there's been a couple more questions in the community forum about hookups, and one person phrased it in a way that I thought was quite useful. What is the best ways to discuss these issues with people who are looking for sex online? How can we do sort of peer-to-peer education when someone is trying to convince us that a casual hookup is just fine? Any tips for how we can spread the word? Nick?
So I might say ACON runs a program called Sexperts, which is a group of peers, volunteers, and we train them how to do outreach, if you like, in digital spaces. So on those apps where people are looking to hook up, and the Sexperts have been operational, you know, but we've enhanced that program over the last few weeks as well. I think it's important to, like in any kind of negotiation that you're having around sex, is to be honest and to be factual, and to, you know, do that kind of negotiation in a respectful way to the person. And it is possible, I think, to, you know, be able to say, well, for me, I don't feel like it's safe for me. You know, that's how I'm feeling at the moment based on this information. If you need a link, I can direct you to links and directing people, but certainly, you know, being open, being honest, and being respectful in those negotiations in any setting, whether it's a sex setting or whatever, needs to remain the principles with which people operate by. If people need more specific tips or even languages or some phrases or some comments, we can look at, you know, providing them digitally, so that people actually have language to use. But I think in terms of thinking about it, honesty, using evidence and being respectful is important in any kind of sexual hookup or negotiation.
Thanks, Nick. Julie? Julie and then Brad.
Thanks, Maeve. You'd mentioned before about people who aren't tech savvy, and it made me think about, well, this question, but also that thing about adaptability. And what I'm finding is that people are adapting and pushing themselves to become more tech savvy, including sexually. And I think that what I'm hearing a lot of is that you don't actually have to be under the same roof to be having sex. And I think that's something that we're kind of learning about as we go. But I've certainly been hearing a real lot of stories about how to negotiate wanting a sexual connection with someone and also wanting to maintain distancing. It's been fascinating.
Brad?
Just to add to that, a couple of things. So one of my patients was saying that he was on Grindr the other day and was just sort of like, chatting with other guys, and then somebody said, oh, look, do you want to come over for a hookup? And he was there going, what the hell are you talking about? So he sort of was able to explain it by saying, well, we should all just be window shopping at the moment rather than going in for the goods. We are needing to have that physical distancing, but it's all right to like have a chat and have a bit of flirting online. But yeah, it's trying to do that in a nice way. And if people are sort of like suggesting a hookup and you're flabbergasted, like window shopping is one of the simple ways of describing it at this point of time. I'm sure ACON will come up with a few more ways around it. Nick?
I might just to add a few little things just more quickly. Absolutely, I think those apps are still a great place for people to be talking, connecting, sharing stories, but not hooking up. But just a word of caution, I think that we need to be mindful of, as we will see increasingly people using technology for sex, just to be mindful of things that they might be streaming or sharing, particularly photos, and what that might mean in terms of, that digital space and the risk and privacy and those things as well.
Thanks, Nick. Before we close, if each of the panelists feel that there's particular information or advice or guidance that they wanted to get across that one of the questions hasn't addressed, there's space for a kind of closing statement from each of you, if you'd like to, or if you feel like you've imparted all the knowledge you have for today, we can also close it off.
One small thing about treatment.
Thanks, Andrew.
Because I completely agree with what Brad was saying about all the treatments that are, there's a flurry of them at the moment. The research is just beginning, and unless you're hearing it from a medical expert, don't listen to Donald Trump for one thing. But one piece of optimism in this field is that most people with coronavirus get better, of course, and that means that the human immune system often works pretty well at getting rid of it. So there's a treatment which we've used for decades for some diseases, where we take blood from people who have got better from the disease, we isolate their antibodies, and we infuse them in people with severe disease. And that is now being trialed in people with coronavirus, and that has the potential within the next 1 to 2 months to be proven to be effective or not effective. We don't know yet. Personally, I think that's the most optimistic thing in the short term. We might have something for treatment of severe disease in a couple of months. A little bit of possibly good news.
That's great. Thank you, Andrew. Brad, did you have some final remarks?
Yeah, there's just a question that came up in the feed, just talking about sort of like partners or sexual partners who might be in a different household. So just to be clear with that, I think the government has said that if you've got a sexual partner and they're another household, then they're still part of your household. This is our lovely ruling that that's being casually described by our politicians. But yeah, I think one of the things to be cautious of and being careful of is if you are living with housemates, being careful who you let into the house and whose house you go to. So there have been a number of discussions of people who are saying, oh, my housemate brought home their boyfriend and I know that they're still like working at a hospital and I'm worried about bringing coronavirus into the house and what does that mean for me? And I think we're all needing to have those very like frank conversations about what we're fearful of, what we're worried about, and who we let in and out of our home, our household, and our groups. And yeah, we're talking before about queer families, and it's who is in your queer family or your queer household, and if there are multiple households that are linked up together from various means, being sane about that. So yeah, we don't want to like 100 people all in that silo, because that's not going to work very well. But yeah, trying to limit things that we can with contact with others.
Jane, did you have some final remarks?
Maeve, I just wanted to talk about, so we've had a lot from community about what's happening with HIV medication shortages, or if there are in fact HIV medication shortages. And I think what we need to say is that we've been told, the pharmaceutical companies who make the drugs have reassured us that they're monitoring those supply lines very closely, that the supply is guaranteed. We're aware that there may be some medications for other conditions that may be in short supply, although we haven't actually heard that from any of our members. But talk to your prescribing doctors. There are other alternatives that can be prescribed. And the issue is around medications more broadly being stockpiled that's causing the delays from the wholesale, being able to get the medications to the local pharmacies for dispensing. So I think they put in place new restrictions around dispensing a 2-month supply, and that should ease that backlog. But I would just say to people, allow yourself plenty of time to get your medication in stock. And there's different ways of getting the medication. So the pharmacies are all doing telehealth posting. So if you keep at least 1 month's supply on hand, and we talked about regional people before and having access through hospital pharmacies, you can also get medication posted to you from community pharmacies. And what you do is you can book your appointment with your doctor through telehealth. They can fax the script through to the pharmacy. But you can also explore Australia Post delivery options. And we've been told by Gilead, certainly, that they're providing all pharmacies who are supplying antiretrovirals with express post parcels so they can continue shipping meds to people living with HIV. So we've got all this information on our website, and we've got a treatments officer as well, so if you can contact him, and a number of people have if they've been having difficulties, particularly those who are here on visas, and it usually can be sorted out simply just with a phone call. So we've managed to help quite a few people that way.
That's wonderful, thanks. Julie, did you want to make some final remarks, perhaps also speaking to the mental health, maintaining our mental health through all this?
I was just thinking that I guess if there was one thing I'd like to say is to keep encouraging one another to reach out if you're not coping, to talking to someone, whether it's Key Life, whether it's someone that you trust, whether it's your shrink. You know, don't wait until you're really, really, really not okay. If you're starting to feel uncomfortable in your anxiety or your mood's kind of getting to you, reach out early and establish or reestablish those relationships now. Everyone is sort of struggling with this to some extent. You're really not alone. So I think keeping that front of mind is really important.
Thank you, thank you. And finally, Justin, did you have some closing remarks?
Just briefly, and just to close off first very quickly about those comments about guidelines around sex. ACON has posted some guidelines on our website, on all of our social media pages. There's sort of fact sheets, infographics and videos, and they're along the lines of what Brad mentioned. If it's a regular partner in your household and you're neither in self-isolation and neither showing symptoms, it's probably fine to keep having sex. Casual sex, please take a break for now. If you have a regular partner living in a different household, the government has said we kind of count them as part of your household, but you do need to be very conscious about social distancing and who the parties have been sort of in the same space as. But please go to our website for information. And then just to conclude a little bit along the lines of what Julie just said, it's important to say that it's okay not to feel okay. It's distressing and challenging for everyone. So I think we all need to have a big dose of compassion for ourselves and those around us. We're all stressed and we shouldn't put unrealistic expectations on ourselves that we're going to be 100% fine or that we should be hyper productive or anything like that. If you do need to speak to someone, ACON counsellors are available online and also on the phone to speak with you. But perhaps to end on a silver lining is that what gives me confidence in our community's ability to overcome what we're dealing with is that we've been in places like this before, beginning when HIV first hit us in the 1980s, and we saw how we responded then with resilience and with care and compassion. And those are the qualities that are already on display, and those are the qualities that are going to see us through this time too. And out of the HIV crisis came new community organizations, new partnerships, new ways of working together, and the same thing can and will happen now. So we will be stronger after all of this, but it isn't going to be easy, and we all need to stay together and support each other through what's going to be a very difficult time for many. So perhaps on behalf of ACON, can I say how grateful we are to everyone who's made time to be here today, to all the panelists as well, to Maeve, and we promise that we'll continue communicating with you, and we'd please ask that you keep communicating with us so that we know what the concerns are of the community. Thank you, everyone.
Thank you so much. I'm just going to reiterate from the start that if any of your questions weren't answered, you can get in touch with ACON by emailing acon@acon.org.au, on Facebook and Twitter as aconhealth, that you can get in touch with QLife by their website qlife.org.au, or by calling 1-800-184-527. Thank you so much. I've definitely learned a lot today, and it feels good to connect with the community. Nick, I believe you've got some closing remarks to end it all, but on behalf of myself, thank you so much. I've really enjoyed today.
Look, Maeve, I do, and thank you so much. Justin has certainly touched on some of them, but to you, Maeve, on behalf of all of us here participating in the forum, but certainly everyone at ACON, you've been a fantastic facilitator. You've kept us moving along. You've kept us to time. It's really been great to have you with us, so thank you. To all of the panelists, to Andrew, Jane, Justin, Brad and Julie, if we were able to be together, we would be giving you big bouquets of flowers. We're so grateful that you've given us your time today and your expertise. I think we had a real richness and depth to your responses. So thanks for being with us. I'd also like to thank the really hard work of the ACON staff who pulled together this afternoon in a really quick time frame, using technologies that we as an organisation aren't completely comfortable with yet and are needing to adapt to. And certainly Brent Mackey, Brandon Bear and Angus Molyneux, who have done a great job at bringing this afternoon together. And of course to Reg Domingo and his extraordinary marketing and comms team for getting the word out there really quickly. Thank you to you, everyone that's been with us this afternoon, for coming along, for tuning in, for submitting questions, for writing commentary and giving questions on the commentary feed. Please be assured that we're cataloguing those and we'll be looking to respond to them all digitally. This isn't the last forum. You'll be hearing from us again. Please keep up to date, as Justin said, with ACON services and programs and how you can access them, either by ringing us up or looking at our website and our social media. But also please check in with some of the other work of great community organisations that we've been hearing from and about today. 2010, of course, the Inner City Legal Centre, Positive Life New South Wales, Mardi Gras is also a great place to go to because they've been sharing a lot of the other community organisation information as well. So it's really important that we all keep up to date with evidence-based information and make sure you go to reliable sources. ACON has always had an approach that whatever we put out is evidence-based. So you can assure yourselves that if you're seeing something from ACON, it has been gone through a number of quality assurances processes to make sure that that information is absolutely evidence-based. So thank you for being with us. Have a great week. Please take good care of yourselves and your loved ones and your immediate network. I think that's where the care needs to start from, with yourself and then your networks, and that spreads. Keep physically distancing. Stay at home if you can, and we realise not everybody can, but if you can, it's a privilege, so please do it. Wash your hands, stay up to date, and always reach out for care and support if you need it. As Julie said, you should never ever feel alone. So thank you again. Peace and love. Have a great week, and thank you for being with us today.
Thanks so much.
Great. Thanks, mate. Bye.